So again, good morning here in Central Europe, good evening in Japan, and hello to everybody else around the world. Welcome to our latest webinar about the basic and advanced treatments for SI joint pain before considering surgery. I want to thank the speakers of today's webinar. Dr. Kurosawa from the Sacroiliac Joint and Low Back Pain Center of Sendai Hospital in Japan, talking about the treatment strategy for SI joint pain in Japan. Dr. Karolina Szadek from the University Medical Center in Amsterdam, giving us an update on SI joint pain from the perspective of a pain physician. And last but not least, Professor Wingerden from the Spine Center in Rotterdam, leading us through possible results with rehabilitation on severe SI joint problems. We will just have all three talks in a row, and we'll start with the discussion right at the end of the last talk. Please use the chat button to do so. Again, thank you to everybody joining us here at our SIMEG webinar. Also, I would like to say thank you to our sponsors, Orthopedic, SIMEG, and Bauerfeind. And please join us at our website, simeg.com, to stay tuned about the latest findings of the SI joint. Okay, Kurosawa, please start your presentation. The first talk.
Yes, I will share my PowerPoint. Just a moment. Do you see? Everyone can everyone see? Yes, but I'm in trouble that I can't see my presentation. Well, oh no, I see. Well, I can start. Okay, I'm glad to have an opportunity to talk about treatment strategy for SIJ pain in Japan. We are working well together with pain physicians and physical therapists, and I'd like to share with you about our clinical practice. Dr. Darrow recently published a book on the current state of SIJ practice in the US. Surgeons and the industry are working together to promote surgical treatment for patients suffering from SIJ pain. The biggest problem is that the surgeons are not fully educated about the SIJ. On the other hand, pain clinics and physical therapists each have their own patients. Dr. Dell described this situation as revolving doors and cash cows. It is a good book to learn about so many issues in the US. SIJ treatment is not so easy, and successfully when the three specialist surgeons, pain physician, and physical therapist work together consecutively and educate each other. In addition to SIJ surgeon, we have two best members in this webinar for this purpose today. We have a treatment strategy depends on three types of responsible for pain. There are SIJ dysfunction in the management of the joint, and inflammation in the joint space, and enteropathy of the surrounding SIJ-related ligament following chronic joint dysfunction state. The SIJ receives a large load with a small range of motion and is vulnerable to joint derangement and impaired function. Repetitive or unexpected movement could cause SIJ dysfunction, and the SIJ is unable to work as a shock absorber. Pain can occur as an alarm signaling abnormality. SIJ dysfunction can cause acute low back and buttock pain, and it can also cause chronic pain if the joint continues to be misaligned. This functional disorder of the joint is responsible for most SIJ pain. When we talk about SIG dysfunction. It means that slight derangement of the fitting of the articular surface between the sacrum and the ilium. The location and symptom originating from the SIG are very characteristic. Patients indicate the superior posterior iliac spine, or PSIS, as their most painful area with one finger. In addition, half of the patients with SIG problem shows the growing pain. They may experience pain and numbness in the lower extremities that does not coincide with the dermatome. Patients often cannot sit on a chair without backrest, but can sit upright in Japanese style seiza. The patient complains of pain when walking. This patient with right SIG dysfunction sometimes showed weakness of her right extremity. This is one of the important papers by Dr. Murakami. When intra-articular SIG injection was performed in patients with typical symptoms and physical findings of SIG dysfunction, only 36% of the patients were effective, and the other 46% were effective with an additional injection into the posterior ligamentous region. These findings mean that the SIG pain originates from the posterior ligaments in addition to the articular area. And surprisingly, the source of SIG pain originates from the posterior ligamentous region in approximately 2/3 of cases. We hypothesized the mechanism by which joint dysfunction causes pain. Histological studies show the presence of sensory nerve endings mainly in the posterior ligaments. When minor joint derangement occurs, the posterior ligament can be hyperextended. Then, the nerve endings in the ligament can respond with pain, which can be felt as SIG pain. Periarticular SIG injection is suitable to diagnose this type of pain. Currently, we use the ultrasound instead of fluoroscopy to perform periarticular SIG injections. This method is very convenient because it allows us to make diagnosis during an outpatient visit. The needle is inserted deep into the sacroiliac joint interosseous ligament region through the short posterior SIG ligament. The diagnostic value is increased if the fluid does not leak into the multifidus muscle. This is a technique for ultrasound-guided injections. We divide posterior area of the SIG into 4 sections designated from 0 to 3. The needle is inserted twice. The first time, we perform an injection for section 1 and 0. Next, a needle insertion point is moved caudally for section 2 and 3. This is our diagnostic algorithm for SIG dysfunction. On physical examination, we look at the SIG scores and the result of typical provocation test. We then perform periarticular diagnostic injections first. If necessary, an intra-articular injection is performed. If both types of SIG injections are not effective, we will look for a source of pain other than the SIG, including lumbar or hip joint. We orthopedic surgeons diagnose sacroiliac joint dysfunction as early as possible and begin corresponding physical therapy. Conservative treatment of SIG dysfunction starts by correcting the joint derangement with manual therapy, including arthrokinematic approach Hakata method and swing Ishiguro method. Swing Ishiguro method is very safety and simple technique. So occasionally we can ask patient family to perform it in their home. Next, a pelvic belt is applied to stabilize the joint and prevent recurrence of joint dysfunction. Finally, abdominal trunk muscle training is performed to increase joint stiffness This is facilitated by an innovative device called Liquor. This device was developed by Dr. Satoshi Kato. He is a spine surgeon in Kurosawa University. This is very useful, and ultrasound-guided selective drawing exercise is also effective. We use 3 types of pelvic belts, including simple rubber belt, smart spine, SI support from Orthopedic company. This allows the patient to tighten up the buttock well. The functional pelvic belt, which aligns the entire pelvic ring, is also effective and was developed by Dr. Tanaka in Japan. This pelvic belt is particularly effective for patients with sacroiliac joint pain and pubic symphysis pain. Using Liquor in patients with SIG dysfunction, we found that ADL was improved in association with an increase in abdominal trunk muscle strength. Since muscle strength can be objectively evaluated as numerical value, the patient's motivation to exercise increases significantly. I'd like to talk about the other pathomechanism of SIG pain. One of these is inflammation in the joint space. In chronic severe cases, Dr. Koga reported that bone SPECT-CT showed increased bone metabolism in the articular subcondylar bone area, which might be a response to the abnormal joint motion. In severe case, the SIG pain would originate not only from the posterior ligament, but also from within the joint space. The third is enteropathy of the surrounding SIG-related ligaments. Sometimes these 2 pathologies can be seen together. For an intra-articular pathology, intra-articular SIG injection is needed. Clinical symptoms that are particularly indicative of inflammation of the joint are characterized by night pain, rest pain, and worsening of pain due to weather conditions. We often use a mixture of 2% lidocaine and dexamethasone to decrease the inflammation of the joint. This is our technique of intra-articular injection via the middle portion. I believe that this is the easiest technique to reach the intra-articular area. The success rate was 80%. When tenderness is prominent at the ligamentous attachment site of the SIG-related ligament, we speculate the pathomechanism of enteropathy of the ligament due to prolonged SIG dysfunction. We often find the strong tenderness point at the medial side of the PSIS and the long posterior sacroiliac ligament and the sacrotuberous ligament, both the sacrum site and the ischial-tuberosity site. Ultrasound-guided injection to each area is useful to identify pain origins. Extracorporeal shockwave therapy, as a tenderness point, is effective to reduce this kind of pain. As you have seen, SIG pain often originates the posterior ligamentous region, but with increasing severity, it can also originate within the joint space and be accompanied by enteropathy of the surrounding ligament. In our opinion, the cases in need of surgery will be in this condition. Esophageal solidation allows patients to return to work. Surgical procedure can be a great benefit to patients in their conditions are identified well. So before the surgery, as you can see, she will not support her weight with her right lower extremities, but now she can squat on one leg. We have performed surgery in some very severe cases that have not improved with conservative therapy. The working time and sitting time has increased significantly after surgery. We surgeons are helped by pain physicians both before and after surgery. Before performing surgery, complication of spine disease must be diagnosed. I do the sacroiliac joint injections myself, but the pain physicians are very helpful in doing all kinds of injections in the lumbar spine area if necessary. They also help me with screening psychosomatic conditions. They are good at screening this condition much better than me. If there is still pain after surgery, they will do radiofrequency neurotomy in the SIJ posterior ligamentous region or spinal cord stimulation electrodes. These are good for the patient. We surgeons are helped by physical therapists as well. We provide substantial physical therapy before surgery. The surgeon, physical therapist, and engineer participate in the SIJ round to share physical findings and discuss of treatment plan. If physical therapist of mine feels that the conservative therapy is limited, we will consider the surgical treatment. Physical therapy helps us after surgery as well. Occasionally, just SIJ fusion surgery does not increase ADL. Surgical treatment is only performed in very severe cases in Japan. Therefore, gait training accompanied by physical therapist is necessary for some amount of period after surgery. After about 1 month, she could walk by herself. The physical therapist will also manage any residual or new onset pain after the surgery. It is also helpful to increase patients' satisfaction. SIJ practice is not so easy. There is a need for all three specialists give their best and recognize each other's limitations. We in Japan have successfully treated patients with all three specialists working together. Thank you very much.
So thank you, Daisuke. So the discussion I think we do at the end of all three talks. So the next speaker will be Dr. Karolina Szadek from Amsterdam, and she gives us an update on SI joint pain from the perspective of a pain physician.
Unfortunately, I cannot take over from you, so you just need to put the next slide.
Okay.
Okay. Welcome, everybody. Welcome from Holland. I am a pain physician, so I will tell you about sacroiliac joint pain from my perspective. And it's a very long journey for me. I started about 20 years ago. And recently I was surfing through PubMed because I'm busy with new guidelines for the World Institute of Pain. And I was amazed by the number of hits appearing on PubMed about the sacroiliac joint pain. Only last year, 215 hits, and the year before, 217. So it's very good for our patients. Next slide, please. And to let you understand why I put this slide on, here you can see the results of a cohort where the authors sought to quantify the burden of SI joint pain. And this was the patients preparing for minimal invasive fusion of sacroiliac joint due to the chronic pain. And you can see and compare the data with the national survey conducted in the USA. It was so-called National Health Measurement Study. So the black bars are given for the general population, and the white bars are given for our patients. And you can see the BP goes for bodily pain. Our patients with sacroiliac joint pain suffer a lot comparing to the general population. Next slide, please. So, and the burden of SI joint pain appears to be higher than in many common medical conditions. They are considered to be very debilitating. The red bar again is given for sacroiliac joint pain. And I marked some diseases. You can see them on the screen, like severe COPD, hip osteoarthritis, and knee osteoarthritis. So you can see that our patient with SI joint pain suffer a lot, and this is very debilitating condition. Please, next slide. There are some risk factors for sacroiliac joint pain. Of course, the leg length discrepancy, abnormal gait pattern, trauma, scoliosis, patients after the fixation of lumbar sacral fixation, the pregnancy, and heavy physical exertion. Next, please. And I know myself everything about it because I go very fast on my skis and I go very fast on my windsurfboard. So I've suffered from SI joint pain many times already in my life, and I do not stop definitely, but it's very, very debilitating. Next slide, please. So during my journey, I took some steps, and I started with the anatomy. And of course, we know all about the connection between the sacrum and ilium. So to create the SI joint and to support actually the pelvis. But what do we know about the innervation? Why did I ask myself that question? I was actually amazed about the fact that all the diagnostics, all the treatment options then 20 years ago was focused on the intra-articular injection of the local anesthetics in the cavital part, the synovial part of the joint. So I was trying to find out why do we think it should be actually positive. So this is at this slide, you can see an overview of the innervation of sacroiliac joint. And you can see that the posterior part, it's very well innervated by the lateral rami coming from S1 to S3 nerve. But there are two studies also describing this of Solonen and Ikeda, describing the innervation coming from also L5 and S4. And in these two studies, also extensive ventral innervation is described coming from the lumbosacral plexus. So unfortunately, the innervation from the ventral part of the joint is denied by the German publication also many years ago, and it was a histological study, and they used some embryological fetal sections, and they could not find any nerve structures at the ventral part of the joint, so they actually denied the innervation of the ventral part of the joint. The next slide, please. So, because I had still had no answer why are we focused at the intra-articular injections, with my group we started some anatomical study, and the dissection was very poor, so we switched to immunohistochemistry. And we took some tissue from the ventral dorsal part of the joint, the ligamentous tissue, anterior ligament, the interosseous ligament, and the iliac and sacral cartilage, together with the subchondral bone. And going back to then, I was thinking about, okay, how could it work? If the cartilage have some scars or, it's damaged, maybe it nudes the bone, and then where the pain come from. So what we did is we stained all the tissue, about more than 1,000 slides with CGRP A and B, and at the bottom of the slide, you can see the staining with substance P, and we saw the very small bead-shaped structures stained with CGRP and substance P. We all know that CGRP and substance P are neuropeptides of nociceptive transmissions. So these structures we classified as nociceptors. Next slide, please. So we was also amazed because we saw some immunoactivity in the superficial layer of the sacral and iliac cartilage and adjoining to the ligamental structures. And with our findings, we suggested that the pain signals from the sacroiliac joint may have their origin from the intra-articular space and the periarticular structures like the ligaments. So therefore, we made the suggestion that the diagnosis of sacroiliac joint pain should include both the intra-articular and periarticular structures. So something more about an innervation. Next slide, please. This is the the very controversial ventral side. This study appeared after my publication. In this study, it was a dissectional study whereby hemipelvises were dissected. You can see here the L4 and L5 going together as the lumbosacral trunk. And you can see this small, very small purple branch coming from the dorsal part of L5 and going straight ahead to the sacroiliac joint. So in this study, it was found that in 80%, the sacroiliac joint is innervated by small branches coming from L5, in 10% branches coming from L4, and together L5 and L4 in 10%. Next slide, please. This is another study, and this is a very, very nice dissection study and very meticulous, which was performed to document the SI joint innervation actually in relation to the bony landmarks to identify points which would give better visibility under ultrasound and fluoroscopy for the optimization of the needle placement during the radiofrequency techniques. At the first picture on the left side on the slide, you can see an overview of their findings in posterolateral view. The black dots indicate the transverse sacral tubercles, and the second tubercle is at the level of the posterior sacroiliac spine. L5 and S4 are given with dashed lines as their contribution to the innervation was found or was inconsistent actually, and found only in 8 for L5 and 4% given for S4. Again, the purple lines, as you can see on the left, this is kind of network, and Roberts and colleagues, they call it the posterior sacral network. So this is a new name for sacroiliac joint, and they also proposed on the right part on the slide, you can see the proposal for the ablation techniques. The first one, the black bar, is the sacral border technique. Then you have periforaminal lateral crest technique given with a gray line, and the white line, the lateral branch. So we have about this extensive innervation of the dorsal part and the ventral part. And then the next slide, please. And then at the end of last year, this study appears, and in this study, extensive innervation of the posterior part of the sacroiliac joint region is described, so kind of a posterior sacral network. But in this study stated that this rami, the lateral rami, do not reach sacroiliac joint. I hope we can discuss it later. Next slide, please. So during my PhD, I moved further forward to making a diagnosis. And from the World Institute of Pain, we still follow the criteria of the International Association for the Study of Pain, in which it stated that the pain coming from SI joint should be present in the anatomical region of SI joint, that it should be stressed positively of the patient's pain should be produced by the provocative tests. or should be completely relieved by the intra-articular injection of local anesthetics again. Next slide, please. So when you search the literature yourself, you will find out that these criteria are not very clear. It was not clear, at least to me. Next, please. So we go to the pain area. Well, wait. We go to the pain area. So the first criteria, the pain coming from SI joint, it has a diffuse character, and you know that it can radiate to the buttock, to the groin, and even to the lower extremity. I had sometimes patients who were complaining about the pain going up to the foot. So concerning the second criteria at the bottom of the slide, there are several provocation tests which have been described to stretch or compress certain tissue in the sacroiliac joint. But here comes my point. The validity of this test was always determined by the diagnostic injections, and usually intra-articular injections. And here we are facing a problem with sacroiliac joint again, because this third ISP criteria, the selective infiltration of the SI joint, whereby the local anesthetics, short-acting, long-acting, are injected intra-articularly. I'll play a role of gold standard, the reference test. But by some authors, by some researchers, this technique is criticized because we do not have data on specificity and sensitivity of this test. And by some, therefore, it's described as not valid for diagnosing of SI joint pain. So with, next slide, please. So with my research group, it was the next step. We investigated diagnostic validity of criteria as described by the ISP. And this is the part of my meta-analysis. And what we stated, or what we found out, is that pointing test, also known as the 14-finger test, has definitely sufficient distinctive power for diagnosing of SI joint pain. Next, please. Well, pain mapping has actually no discriminative power, but this study I want to discuss because it's very interesting, and it gives something about the pain mapping, but also about the intensity of mapping. Here you can see the responders and the non-responders to the double injection, intra-articular injections with local anesthetics, the lidocaine and bupivacaine, or during 2 different appointments, and you can see yourself that there is actually no difference between the radiating pain to the leg, to pain in the groin between the responders and the no responders. Next, please. But if you take a look at the intensity mapping, then you see that the responders to both intra-articular injection give the most intense area around the sacroiliac joint, so in the 14 area, around the anatomical region of SI joint, whereby the non-responders give the most intense area around the ischial tuberosity. Next, please. So I go back to the meta-analysis. According to our meta-analysis, there are some provocation tests which are very good to use for the diagnosing, and this is a compression test, titras test, and if you perform 5 provocation tests and 3 or more of these tests are positive, it gives you also a good validity for diagnosing of sacroiliac joint pain. The next, please. And then we come to this conservation intra-articular diagnostic infiltration. There are no data about the diagnostic validity of the complete pain relief of the infiltration with local anesthetics. And why not? The next slide. Well, it's very differently interpreted. So in the research, some use single, some use double injections. So during the 2 different appointments, they inject lidocaine, and then during another appointment, for example, long-lasting local anesthetic. Some of our colleagues use also corticosteroids intraarticularly, and there is a discrepancy between the volume injected in the sacroiliac joint, and it also varies between 1 to 4 milliliters. And the last point is that ISP describe it like totally pain-free after the injection, and our colleagues describe it like 50 to 90%. So in some researches for pain relief, 50% pain relief is required, and in some researches 90% of pain relief is required. Next slide, please. So we draw a conclusion from our meta-analysis that the 14-finger test, titras test, compression test, 3 or more positive provocation tests appear to have sufficient distinctive power for diagnosing of sacroiliac joint pain, but taking into account that there is no golden standard. Next slide, please. Yes. And this is also nice. It's not my own study. It's a study of Joseph 14 a long time ago published. And according to this study, there is, if you inject something intraarticularly, these are some arthrograms, and you see in 61% of all joints some extravasation patterns. And 3 of these observed patterns show pathways of communication between the SI joint and nearby neural structures. And these extravasations included the posterior extravasation into the dorsal sacral foramina, superior extravasation to the third lumbar nerve, and the ventral extravasation to the lumbosacral plexus. And Joseph 14 used a mean volume of the dye. It was like 1.08 cc. So, and in the range of between 0.5 to 1.8 cc. Okay, the next slide. So the treatment options. Well, again, from the World Institute of Pain, we followed this diagram actually. So if we have patients with sacroiliac joint pain who are referred to our clinic because they are refractory to conservative treatment discussed by Daisuke already, then we propose the intraarticular injection with local anesthetics and corticosteroids. And if it gives only insufficient or short-term result, then we should move to the radiofrequency ablation techniques. And there are a lot of them. Unfortunately, in Holland, these techniques are not reimbursed. So if the patient wants to be treated with radiofrequency treatment techniques, then they really need to pay themselves. I will go through the techniques now. Next slide, please. This is the technique we describe in our guidelines of the World Institute of Pain. So we used the 22 gauge needle, 10 centimeter long, and we approached the most dorsal, most caudal region of SI joint to put some contrast medium, the dye, intraarticularly to just confirm the position of the needle intraarticularly. And then we inject the local anesthetics together with corticosteroids. And this is actually our technique. Nowadays, of course, there are some techniques also described with the ultrasound, but I hope they will come in the new guidelines. Okay, next slide, please. Well, the strategy from Japan, Daisuke discussed it already. I think it's much easier. So Professor Murakami investigated this periarticular versus intraarticular injections. And he found out actually that the periarticular injections are very, very frequently positive or effective in our patients with SI joint pain. So only 90% of patients had to be treated with the intraarticular injection after they got the periarticular injections like described by Daisuke previously. Okay, next slide, please. So I will go through the techniques which we use for radioablation. At the tables, you can see the targets of the needle to the neuroforamen. Then you can see this lesion diameter made by during the ablation. Then you can see the anatomical findings coming from the research of Roberts and colleagues. So how many many lateral branches you can capture with particular techniques, and some clinical outcomes coming from different studies. At the right part of the slide, you will see the pictures, the radiograms of the coming from the study of Roberts. This is an anatomical study. It gives a perfect visualization of the needle position. So in this first technique, the periforaminal bipolar RF radiofrequency, whereby also a monopolar lesion is done of the dorsal rami of L5, you can see that that's a wonderful, is it blue or purple lesion made between the two needles periforaminally. So with this technique, you will capture like almost 93% of the lateral branches with clinical outcome of 50% pain relief after 12 months. Next slide, please. The conventional monopolar technique, you see yourself on the right side that it's only small dots, so the lesion is not very nice, actually very small, and it takes like 4 millimeters in diameter. So you will capture only 12% of the lateral branches. However, clinically, it can have some positive results, and in 11% you will get positive results of 50% pain relief after 12 months, according to Cohen and colleagues. Next slide, please. This is the ablation with the cooled technique, again a monopolar technique. And you can see that the lesions are much bigger, so like 10 millimeter in diameter, and you will capture about 92% of the lateral branches with the good pain relief up to 12 months. Next slide, please. Then we have this palisade technique, which is probably the easiest one and frequently used at least in Holland. And again, you will get the great lesion between the needles, and you will capture almost 100% of the lateral branches with a good pain relief in 74% of our patients up to 3 months. Next slide, please. This is the special needle, the Nimbus continuum needle. Again, with this, you will get a very good lesion. Actually, everything is burned away. However, we do not have any clinical records on this technique. And according to the anatomical study of Roberts, you will capture about 70% of the lateral branches with this technique. The next, please. This is the simplicity technique, was not studied by Roberts in the anatomical study. You will create with this needle very large lesion, and you can reach like 50% pain relief up to 36% of our patients after 12 months. Next slide, please. And this is the posterior sacral network technique, advised by Roberts and colleagues. And again, with this technique, you will capture almost 100% of the lateral branches with the good follow-up. Almost 26% of our patients will get pain relief up to 12 months, more than 50% of the pain. Next slide, please. So at this slide, you can see the comparing between this radiofrequency techniques, actually technical efficacy and what you can capture with the needles. And you can see that the monopolar techniques is actually useless, and I do not advise it. Definitely all the bipolar techniques, the cold RF, where you create greater lesions, are very good to do the radiofrequency techniques. The next slide. And this is the last one. So from my presentation, I would like to conclude that the innervation of the dorsal part of the joint comes from lateral branches coming from S1 to S3 and ventral part from L5. Based on our own research, we can state that the SI joint definitely can create pain because there are some nociceptors found in the intra-articular and periarticular sacroiliac joint. There are some tests which are useful for diagnosing SI joint pain, like 14 test, maximum pain in the 14 area, and the provocation test. I would like to advise that we should focus not only on the intra-articular, but also the periarticular or pericavital part of the joint. And there are some a lot of techniques actually described for the radiofrequency techniques. We do not have nowadays any comparative studies, so I cannot say which one is the best one, but I would say use the technique with the greatest lesion. Thank you.
So thank you, Karolina. This was a great talk. I liked it very much. I learned a lot. Again, we discuss it at the end. So next speaker would be Professor Wingerden from the Spine Center and Joint Center in Rotterdam. And he will just give us some insights about possible results with rehab on severe SI joint patients. Thank you, Professor Wingerden.
Yes, Volker, thank you very much. I hope you can hear me talk at this moment. I put on my microphone.
That's good.
First of all, I would like to thank Daisuke and the SIMEG organization for asking me to do this presentation. I feel very honored. Secondly, regrettably, I'm not a professor. It says I'm a professor, but I got my PhD, but I didn't make it to be professor. So you have to do it with only someone who has his PhD. In my daily function, I'm director of the Spine and Joint Center in the Netherlands. And from that, we learn a lot about pelvic girdle pain patients. And the organization asked me to tell you something about how we treat our patients, what kind of results you can achieve with the conservative treatment, and when this kind of treatment does not work. So I will take you along in a short history about our way of treatment and what can happen. So what we're going to talk about is, first of all, you have to think about what can be the assumed cause of chronicity in the pelvic girdle pain. There's a difference between getting pelvic girdle pain and chronicity of pelvic girdle pain. There can be different mechanisms playing a role here. So I would like to talk a little bit about that. And then I would like to show you what kind of patients we are talking about, because there are many different kind of patients, and it's good to have a view on what kind of patients we are focusing on. Then I will tell you a little bit about the conservative treatment of a pelvic girdle pain patient. Of course, for our organization, it's rehabilitation, but you can also do the same in a physiotherapy practice, for example. So we can talk about that. And then I can show you what you can expect from that kind of therapy and when you have to expect it. What time period do you take for treatment in a patient like this? And then finally, I will talk a little bit about in what cases we will have a diminished result and maybe have to be doing an operation or another kind of intervention like the kind of Karolina has been talking about. So first of all, I would like to talk about the causes of chronic pelvic girdle pain. And I don't know how it is in the rest of the world, but in Holland, the psychological aspects of chronic pain take a big flight. So what you see is that when pain gets chronic, it's mostly because there's emotional discomfort, avoidance, and that may lead to more pain. But what I would like to show you is that in this case, that is definitely incomplete. This kind of patients really have a physical problem underlying the emotional aspects. So even though emotional aspects do play a role, there's also a physical aspect in these problems which need attention. And I would like to show you some more about this. For example, this is a load transfer test or the stored standing test. And this is a bit more severe patient, so it makes very clear what's going wrong with not being able and standing on this test. And that's what's happening in these patients. There really is a physical problem. This, for example, is the active straight leg raise test. And look at what she's doing with her body, trying to lift her leg, the extension she is making, trying to get the leg lifted, which is just not possible. This is an extreme. I will show it again. One more to show you what's happening. Sorry. I'll show it again to show you what's happening in lifting her leg, the trouble she has. This is a somewhat more severe patient. You also have people who can lift their leg, but have not so much this kind of behavior. Then the question is, how can we explain this kind of behavior and what's happening? So we start with the model of form and force closure, which was coined by Snijders and Vlaming, which says, and I hope you can see my mouse here in the image, that the connection between the form of the joint and compressing the joint, the middle layer, the middle picture, makes a kind of combination with a kind of form and kind of compression, which gives the stiffness and control in a joint. Now, in the SI joint, which is very important, we have found that the shape of the joint, here you see an SI joint, this is the ilium, this part is the sacrum, this is the joint. You see this kind of roughness in the joint, and it's not a smooth edge, but it's curved like this. And that tells us that the form of the joint, if you compress this, if you put it together, it will give more stability to the joint. And at this part, I would like to make already a remark to the lecture of Karolina, which she says that there's a question, how much fluid to inject in the joint? And what we sometimes see is that you have patients who have, after an injection in the joint, get a kind of release of the joint and a sudden increase in problems, because the fluid that is injected in the joint prevents the compression of the joint and makes the problem worse instead of better. So what I would think of is, if you have a choice in injecting a lot of fluid or very little fluid, I would definitely suggest that you do as little fluid as possible, because it can have a negative effect on the compression of the joint. So this is the joint surface. That's the form part of the whole system. And then, of course, it gives you this kind of tooths that pick into each other and give stiffness when compressed together. And this compressing together is done by external force from ligaments, from muscles, but also, for example, the position of the joint. If the joint is in the nutated position, it will be very stable. If the joint is in a loose back position, like the counter nutation position, it will be less stiff and less robust to use in daily life. So what can be causes of pelvic girdle pain? Well, we saw Karolina already say something about what kind of causes there are. Have been many years that we thought that pregnancy was the cause of pelvic girdle pain, but now we know that's not so much the case. You have to say that pelvic girdle pain is caused by some kind of overload. in which pregnancy can play a role, because the changes in pregnancy make the capacity of the joint a bit less, which enables or makes some kind of overload much easier. But you can also have trauma, but even surgery. We have people who have, after surgery, get some pelvic girdle pain because the control of the abdominal wall is not optimal. And when you go to chronicity of pelvic girdle pain, then there is a disbalance between the load and capacity, which continues. So the robustness of the SI joint, the control of the SI joint is impaired, and then behavior plays an important role in the continuation of this kind of complaints. So how can we explain that? So if we have the joint, we need some kind of compression of the joints to make it stiff. But if we have a non-optimal SI joint control, like there's an incidence of disruption of the SI joint because of something that happened during pregnancy or by trauma, you get a non-optimal SI joint control. Because of this non-optimal SI joint control, you may easily overload the SI joint with some kind of inflammation. This inflammation produces some kind of fluid in the joint, which disrupts the control of the SI joint, which fills and makes the circle complete. So from non-optimal SI joint control, you go to some continuous SI joint overload, and this SI joint overload causes an inflammatory process, which in itself causes the non-optimal SI joint control. And this is the circle which continues with chronic pain patients. And that's something we have to break through to get some improvement. So this is a kind of pelvic girdle pain patient you see walking here. And this is the group I would like to talk to you about. We're talking about chronic pelvic pain patients. It can be both women and men. And in this particular group, the duration of the complaints is more than 3 months. And as you will see later on, it will be much more than 3 months. And like Karolina already said, these patients are seriously limited in daily function, and regrettably, they are very often therapy resistant. So many other treatments fail in improving this kind of patient. So some years ago, we did an analysis on this patient group. This was a group of 245 patients, 150 women and 95 men. And what you see is the duration of their complaints is not only more than 3 months, it's almost 9, almost 10 years. We have done other groups with 6 or 7 years, but this is a long time that these patients can have their complaints. Some of them have legal procedures, that's about 20%. Some of them have also radicular symptoms, that's about 1/3 of the group. And they have even a diagnosis of a herniation of in the lumbar spine, which is also about 30%. They have had denervations, 14%. They have had rehabilitation, also 14%. Many of them, almost 95%, use medication, and many have had pain injections, 82%, without giving them enough relief. They have consulted about 3 to 4 specialists and have had a lot of physical therapists before they come to us. And the most of the group used a kind of assistance in their daily life. So this is really a very heavy and difficult group to treat. And here you have an example of such a patient, and it's a bit not so a worse patient as you have seen before, but you will see that there are some parts of the activity of this lady which are impaired, like the way she's moving and putting her foot on the floor, which shows that the impact of just walking can already be somewhat impaired. And also when she's standing up again and bending forward, you will see some problems in how she moves. There's a lot of tension in the hamstrings, and not enabling her to bending forward fully, but also her lower spine has a lot of tension. And these can all be parts of the compensation strategies you will see in these ladies. A difficult thing in these patients is that they almost all seem to do some part of their daily activity, which is possible, but which gives them a lot of pain if they do it, but they get the pain afterwards in what they do. Here you will see the load transfer test again, and you will see that there's some disturbance in balance on both sides. She cannot really last very long. And also the active straight leg raise test, which I'll show you, will have some limitation. She will be lifting the leg. This was not so bad. And you see she can lift the leg, but if you look closely at what she's doing in this area of the spine of her trunk, you will see that she's doing some kind of compensation strategy. So what is the kind of treatment we are doing with this kind of patients? Well, first of all, you have to get them in the right state of mind. Many of these people have tried anything and they just don't understand their complaints. So the first thing you have to do is explain them what's happening in their body, and that they have to make the right choices and accept that there's a problem and make the right choices to get to some kind of recovery. If they don't do that and they continue the way they've been doing for many years, they won't recover. So their state of mind and understanding the problem is first of all what they need. Then secondly, the strange thing is that from the psychological aspect, it's thought that many chronic pain patients, that they avoid their activities and that they have fear of their activities. But what we see is that most of the patients, they continue despite their pain. They are too active and continuously overloading their pelvis. So the second part we do in the therapy is that we try to physically unwind them, to relax them by relaxation exercises. Not so much the mental relaxation, but much more the physical relaxation, the release of muscle tension. And we do that by giving them the relaxation exercises and having them take resting moments about every 1 or 2 hours for about only 10 minutes, which is sufficient. And the first time they do it, they really hate it because it gives them more pain. But after 2 or 3 times, 2 or 3 days already, they get some improvement on their complaints. Then if their body is in a state that we can start working with it, then we start doing some physical control. It's basic fundamental control and trying to get their abdomen and transverse abdominals working again to support the pelvis. And from that, then we slowly start building up strength and capacity of their bodies. And then the final stage is that they can make the transfer from using their body again to daily activities with more endurance, more force, more impact, and that they can start doing their daily activities as normal as possible. So if you want to have a picture on how the therapy looks like, in the first phase of the therapy, if we start a therapy which lasts for about 4 to 8 weeks, here's the end of therapy, and then they continue to train for themselves. But in the initial phase of the therapy, many therapists, they already try to start training patients. So they start to go from here, go up to better function, which is not the idea. If you do that, because of the overload of the SI joints, patients will get worse and not better. So the first thing you have to do is relax them, get the tension off, and get them in a state that they can be trained. You have to make the comparison with an athlete who has been doing some overtraining. If you overtrain an athlete who is already being overtrained, you will make the situation worse. So even an athlete who's been overtraining should relax first before you can start training again. It's the same thing with this kind of patients. You have to release them first before you can start training. So the first 2 weeks we used to get here. And then in the second phase, we start building up with giving them more compression, more stability, more control, and then building up. And in the third phase, we're going to really train them with higher activities and starting already to get some more activities in daily life. And then we transfer that to the final phase in which they can pick up their daily activities and work and go back to work and activities. You don't have to avoid most of the things they do in this kind of phase. So we've been doing a lot of studies on these patient groups, like this one from Karen Perkerk, in which we showed that there are some factors which you can deal with in understanding which kind of patients are responding and which kind of patients are not responding. So after 8 weeks of training, this is the same patient you've seen before. Now this is 6 weeks later, the second video. And when we ask them, what is your impression? About 73% says they do better to much better, which is a very good improvement on their daily function. We also test that in other ways. Like, for example, here we have the minimal clinical important change analysis. What we do in every patient is we ask them the number of pain they have, the amount of pain they have, by using a visual analog scale. And we do the same with limitations in daily life by using the Quebec Back Pain Disability Score. That's the score on this side. And the minimal clinical important change says that the final score in the end of therapy should be 30% less than the initial score in therapy. So if a patient by the beginning has about a score of, you might say, 70, and then the end you get a score of 20 or 30, that is an improvement or 30% or more, and that's a positive minimal clinical important change. And we try to find how many patients we treat have this 30% improvement or more. And then you see that with the pain VAS, we see that more than 65%, almost to 70% of patients have a clinically relevant improvement in their pain. And more than 50%, 55% has an improvement in daily function. And this improvement even improves after a long time. That's what I can show you in the next slide. This again is the patient. I will show you the patient first. This is the patient after 6 weeks of therapies, because in the first week we do the first video, and then in the final week, which is 6 weeks later, we do this second video. And what you see is she is much more free in her motion. It's much more power. There's much more dynamics. She is not quite released already in all the tension there is. That can improve some more, but the motion is already much improved. And even in the lifting, which you will doing here, the pen, it's much more flexible and much more easy. She has already more power. And this in the coming months can even improve further. We'll see if she's got more balance now in standing on one leg, which is, and on the other side, this is just a little bit still, but much more better. And let's see what she's doing with the active straight leg raise test. And you can see in all her motion activity that she's much more free in her body, and she can do it much more easily. And also what you see here, the abdominal here, just a little bit still, needs some extra work, but there's already much improvement. So some years ago, we were asked by the insurance companies what our long-term effects were. So we did a study on about 700 patients of ours over a period from 2012 to 2015. And we asked all these patients, that was the year 2017, what their status was at this moment. And what you see, and that's very striking, this was the period of the therapy, and there you see the improvement in the therapy. But what's very interesting, it doesn't go back up again. It stays here down and even improves a little bit over time. The same here for the pain, the improvement during therapy and improvement afterwards, because the patients know what they can be doing. They can work on their physical improvement and continue this in the years after, which is a very good result. It's not going back to the old situation with their initial limitations and pain. So the conclusions we can make on this study is that the conservative treatment is absolutely possible, and in very many cases it can be very effective. But the question is, what kind of concept do you apply to the therapy? That's very important for yourself as a therapist, but also to explain to the patient that the patient has a concept they can work with. And it is focused at physical recovery. Many chronic pain patients are now treated psychologically, and that will not be sufficient in a chronic pelvic pain patient because there's a physical problem underlying this problem. But still, again, you need behavioral change to make a better function in the pelvis. So despite the fact that there needs to be physical recovery, you need to also approach the physical aspects of the treatment. The patient has to take the resting moments and start doing some other things in their behavior. If they continue their overload, they will not improve. So you have to first neutralize the compensation. And if you do that, the first effect will start within days. It's really, we are ourselves always surprised again and again if we have a patient with years of pain. If they do the right action, the right activity, the first days and weeks, you will have an effect within days. And the treatment will be successful within 4 to 8 weeks. And the full recovery you will see about after 1 year to where the patient ends up. And this is a bit the process you can find if you have a conservative therapy for your patients. So the results will endure over years if the patient has to do. Sometimes some patient can have a fallback, and then you have to pick up the line of treatment, get back to the resting moments a bit and pick it up again, because the pelvis can be susceptible to some overload again. And then you have to go back in your load and start the therapy over again, just a little bit, not completely, but just a little bit. So what we find, what can be causes for non-success in the treatment, is sometimes you have patients which are severely impaired from a structural perspective. For example, if there has been major trauma with open book trauma in the pelvis, then it can be that the structural integrity of the pelvis is such that training will not help. It's too much then. So that can be one factor. Another factor can be that there are complicating factors like another kind of underlying disease, like multiple sclerosis, Parkinson's, a cerebral palsy, rheumatism, or back derive. If you have these kind of underlying diseases, it complicates the training of the patient, and that makes the results more difficult. Then there can be something with an insufficient diagnosis. There can be other things happening. And if we miss these confounding factors, then therapy of a pelvic pain patient gets more complex and not so successful. But then the biggest part of problems you can have in a pelvic pain patient, from our perspective at least, is the non-compliant behavior. One thing can be that the patient still thinks something very terrible is happening with the pelvis, which makes them avoid motion and avoid activity in which you cannot train the patient, which makes the therapy very difficult to perform. Or the patient is not taking its resting moments, which keeps the overload continuous, which also makes the therapy much more difficult. Sometimes, for example, if the patient has had a mental trauma or is very stressed out, then they're not able to relax enough, and that also complicates your therapy. And there can be other kind of ways in why the patient is overloading themselves, because they have to keep on with their work for financial reasons, or they have to take care of their children, or there are mental reasons why they cannot take resting moments. There can be all kinds of social stressors not allowing the patient to take resting moments, which complicates the therapy very much. And you have to take care of that. And then there is a very small group of patients, less than 5%, in which all these things are taken out of the equation, and still we don't know what's understanding or what's happening there. But that's only a very small amount of the patient in which we don't know what's happening. And then you have to go back to other treatments like the kind of Karolina is speaking about, or maybe an operation in some cases. So that's my presentation about what you can do with a patient. And this guy you see here, it was a young guy who had a problem in his pelvis. You see the load transfer test disrupted on the left side. And after some weeks of therapy, you can see he is picking up his basketball again with full being able to load his pelvis, hardly no limitations anymore. While on the left side, you see his problems in his active straight leg raise test. If you have a good conservative therapy for pelvic pain patients, you can have a lot of result. The basic thing is not very difficult, but the performance of the treatment can be difficult. So I have to warn you to take care, to take the steps very meticulously, and then you can have your good results. So This is the end of my presentation. I hope I have given you some information on what kind of results you can have, and I will end it by here. Volker, I give the word back to you. Thank you very much.
Thank you, Jan Paul. Great talk. I learned a lot, and also great results, I would say. Almost better than we have as a surgeon. If we look at your VAS, very good. I liked it very much. And I also learned that we need to do a good physiotherapy with the patients. Your last example was very impressive here with the young patient playing basketball again. Very impressive.
Thank you.
And also we have to be aware that we need to have a behavioral change, as you say, with the patients, and that they get that they neutralize this compensation mechanisms they have in first line. So I think we have to work a lot more in the conservative way with our patients before thinking of an operation. Thank you. I move back to Michael Dirks because he's the administrator and he can see the questions you just asked in the chat room. So please ask now the three presenters what you want to know, and they will, I hope, they can answer your questions. So Michael, please do so.
Okay, so there are some questions. I would start with the questions to Dr. Kurosawa, I think. There's one question: why is the tenderness of the sacrotuberous ligament so important?
Thank you. From Volker. Yes. The tenderness of sacrotuberous ligament is important for from two aspects. The one is we often check the tenderness point of ischial tuberosity site. This is one of the site of the sacrotuberous ligament attachment site. So if the sacrum over-nutated for a long time, the sacrotuberous ligament hyperextended for a long time, and the attachment site here is painful. This sign, the strong tenderness point of this site suggests the chronic sacroiliac joint dysfunction, we think. So under the other aspect, this site is the attachment site of the biceps femoris. If the patient has a tight hamstring, the biceps femoris muscle connects to this, and the sacrotuberous ligament is connected to this, and these two components connect with the fascia tissue. So if the patient has a tight hamstring, it can be possible to recurrence of sacroiliac joint dysfunction. So we focus on this site. I'd like to know the Jean-Paul's way of thinking about the sacrotuberous ligament, because he published a paper about that, connecting to the biceps femoris. How do you think about it?
Thank you, Daisuke. I think you're very right. There's one thing I would like to put in the discussion, and that has to do with the question we are very often struggling with. If you have a patient with pelvic girdle pain, we very often assume that in a normal situation, the SI joint, when you stand up or sit, the SI joint should be in the nutated position. So the sacrum will be just a little bit forward relative to the ilium. What we thing we very often see in pelvic girdle pain patients is that because of the inflammation in the joint, you get this building up of fluid in the joints, which presses the joint in the most loose pec position. And in the SI joint, that would be the counter position, the counter-nutated position. So, and that's again also something for Karolina to maybe discuss. That is, if you look at the 14 finger test, the question we have, is that a test for SI joint pain, or because what the ligament that's being stretched then is stretched during the counter-nutation? So it's the long dorsal ligament. So for us, the finger 14 test, the one finger test, or the long dorsal ligament test, is for us a test to understand that the patient may be in counter-nutated position. Now, and I'm going to finish this story because there will be other questions. If the joint is in the counter-nutated position, the sacrotuberous ligament is becoming insufficient because it needs the regular tension from the nutation and then connect the SI joint. But if the sacrum is in counter-nutation, then the sacrotuberous ligament is too loose, and the hamstrings have to work harder to tense the sacrotuberous ligament. So altogether, it's a kind of compensation strategy, which gives you a lot of friction in the bursa, which is on the ischial tuberosity. So that for us explains the mechanism, what's happening there. But that can be something which you think different about. So that's our perspective on it.
Oh, thank you very much. Your idea is new for me.
Okay,
Very
we have to talk about that some more sometime.
Daisuke, I have a question. I saw in the chat that you asked many questions to Jan Paul. Are your questions already all answered, or do you want to proceed?
Yeah, no. No.
I've not yet seen the questions.
No, I have still a question.
Okay, then I would say first we go to Dr. Szadek, questions to Dr. Szadek, and then we proceed. So there's a question, Dr. Szadek. In the publication of Dr. Steinke, they found out that the nerves do not reach the SI joint. If this would be true, why intra-articular injections are effective? A question from Volker Fuchs.
Thank you, Volker. I think we have to stop to think about the sacroiliac joint as only intra-articular parts. I stopped it already 20 years ago, and I see sacroiliac joint as the whole structure. So together with the ligaments and the intra-articular space. And for me, it would be wise to, for example, inject corticosteroids in inflammatory joints. But I do not actually see the reason to put anything in the intracavital space whereby we do not have any inflammation seen on the MRI, for example. So as it has been shown already by Dr. Murakami, that the periarticular structures are very, very also prone to relieve the pain, actually, if we inject something periarticularly. So Dr. Steinke describes the nerves like Dr. Roberts did. So it's also the posterior sacral network kind of structure, and it's not reaching the SI joint. And this is my question. What do we mean with the SI joint? Because I see this as the whole part, so together, not only intra-articular part, but also periarticular structures. And well, this is very good study, but I still have some remarks on it because there is no immunohistochemistry. We cannot prove that the nerves do not reach the intra-articular space. So, how more I know about the sacroiliac joints, how more question I have actually myself. I think so. We should focus on the cavital space if we have inflammatory patients. So if there is an inflammation, for example, with Bechdrev, or with Crohn's disease, or something spondyloarthropathic diseases. But I don't see the reason anymore to inject anything. And well, Jean-Paul, you agree with me that it can even damage. What we see, I saw you this with a very old study actually of Joseph 14. Then with even 1.5 milliliters of a dye injected intraarticular, we just reach some extravasation to the nearby structures. So I think actually that if we don't need to put anything intraarticular, don't do it.
Okay.
Can I say something about that, Karolina? Do you mind?
Yes, I don't mind.
I so agree with you, because what we call the joint space, is really the disruption or two parts of bone. So actually, it's a hole which is filled with some fluid. That's it. So how can you have pain in a hole with fluid?
Have you ever tried to extract any fluid from sacroiliac joint?
No. I don't. We don't do that. We don't do that. So, you're right, because it's very compressed. There's hardly anything in it. So, and there's another thing, and I because of what you said, I was thinking about that. What we have to realize is that maybe some aspects of the sacroiliac joint itself, like the ligaments, the surrounding ligaments, or the capsule, they can be painful sometimes. But what we have to realize is that dysfunction of the control of this system can have effects in all kinds of other parts in our bodies. We have people with pelvic girdle pain who also get neck pain, hip pain, foot pain, knee pain, because of their compensation strategies to avoid what's happening around this joint. So if we just keep focusing just on this little bit in the joint, don't make just to the patient and the problems they have.
I think we should observe our patients starting from the walking to the exam room.
Yes, so, definitely.
I always walk with my patients in the examination room, and then I see them, and I usually I let them walk before me, so I follow them, and then I observe them what happens, and well, my exam room is not that big as yours. All the exercises, but I do agree with you. Well, I've learned from Flaming that we should see our bodies at the ship. So if something happens with the bottom of the ship, or if something happens with the mast, other structures need to take over it. So I also see our patients with sacroiliac joint pain suffering, or also afterwards with the knee pain, and then lumbar pain, and then with thoracal pain. And so it's, well, they get more and more disabled, actually.
Yes, I agree with you.
But then we have a problem with our tests, with our test strategy, because all those tests, as you told us, Karolina, are just made with intra-articular injections to find out the specificity, and then we have to rethink this.
Well, I think we just need to start over. And first of all, we just need to agree on the technique, periarticular technique for the diagnosing of sacroiliac joint pain. What do we think is important? How many milliliters do we need to inject? What do we need to inject? How many times? Because there are some strategies. If you want to publish a paper on a sacroiliac joint pain nowadays, you need to use, for diagnostic reasons, you need to use at least 2 injections with local anesthetics, lidocaine, short-acting, and long-acting. I think it's where terrorizing actually our patients. So if we first start with agreeing with each other, what should we do and how do we need to diagnose our patients with local anesthetics? And I think a lot of things we hear from history taking and from just looking at our patients. I don't think the needle or operation is always needed. And Jean-Paul show us the data of his research. So if we only have like 5% of patients not recovering after 1 year, then I would say let's focus on this together on this 5% and why do they not recover, and be the guidance to our patients just to move on. And I would say to spine and joint center.
Well, don't send them all to us because we can. I agree with you, Karolina, but I would like to make one suggestion. I don't think we have to start all over again because going back to Vesalius, that will be a bit too much. But the thing is, I think we have to learn to zoom in and zoom out. We have to learn to sometimes zoom in the little aspect of the SI joint and sometimes zoom out to what is this patient actually doing with his body. If you can do that, you can see much more on what's happening already. So that's my 5 cents worth.
Okay, I have a proposal. Since most of the questions here in the chat room are posed by Dr. Kurosawa, by Dr. Fuchs, so I think you know all your questions. And do you want me to read them all, or do you want to just ask them? And so we have a regular discussion, because I don't see any other chat and requests from any other participant. And if there is any other participant who wants to ask a question, I would say he can unmute his microphone and just raise hand and discuss.
I have remarked on that, Michael. I am not allowed to put any questions in the chat room.
I see. Okay.
I think
the same problem.
other participants have the same problem, so that's why you have the questions from Daisuke.
Oh, I see. Okay, so this is something I have to. I'm sorry for that. So this is new for me. So if you continue with the discussion,
Michael,
yes.
it's Dr. Ijin.
Raise his hand.
Yes.
From Indonesia.
Yes, he can unmute his.
Thank you. Greeting from Indonesia for all the speakers. Very wonderful talks today. And hello, Daisuke Sensei, my old friends. I just want to ask about the treatment of the SI joint. Daisuke, you mentioned that if the SI joint is ineffective, so you will perform another test for excluding the pain generator, like a lumbar disc block or selective nerve root block. So how long after the first injection you will perform the next injection, whether it is lumbar disc block or selective nerve root block? And my second question is, Karolina said that there is still no golden standard for the diagnostic criteria. Is there a minimum criteria for the diagnosing the SI joint dysfunction? Whether is it from the physical findings or the radiological findings? Thank you.
Dr. Jinten, thank you for your question. So I performed the sacroiliac joint injection first. During 2 or 3 days, I will observe the effectiveness of the injection. If my sacroiliac joint injection is not effective at all, I will try to next diagnostic injection to lumbar spine area. But the patient has 50 or 40% pain relief. I will perform the sacroiliac joint injection again. 2 or 3 times sacroiliac joint injection can gradually reduce the pain. So it's a variable for diagnostic sacroiliac joint for the patient. So my answer is that if the sacroiliac joint is not effective at all, I will look for the other pain generator in lumbar spine area or hip joint area. That's my that's my answer.
Thank you, Daisuke. Very clear.
Thank you for your question. It's a very difficult one. Well, I still follow the criteria as I described it for the World Institute of Pain, and actually it's the criteria we discussed recently of the International Association for the Study of Pain. But we come also across a problem because, again, I don't look only at the SI joint. And so I look at the patient, and sometimes you have this mixed problem, as we discussed it already. So people with SI joint pain have also can have also facet joint pain of discogenic pain, or they have dysfusion, or they have the instability. So there are a lot of problems, and we just need to think about them at once, actually, when we see our patients, and try to make a best diagnosis and start with something, or try to eliminate some other diagnosis, and finally, after the workout, put a final diagnosis. But in my opinion, it's very difficult sometimes. So in the last 20 years, I still find it's very difficult to differentiate, for example, between the facet joint pain, especially the last one, between L5 and S1. So and the SI joint pain. So usually what I do is just look at the patient, take the history, follow the criteria, and try to do my best to put the right diagnosis. And sometimes, unfortunately, I'm wrong.
Thank you, Karolina. It's also same with me. SI joint disorder and lumbar spine disorder is still like a gray zone to me. Sometimes I overdiagnose also.
Can I have a question to the orthopedic surgeons? I see some patients after the fusion who still suffer from the pain. I would say if you put something together and it cannot move, then you should stop the pain or the suffering. But it's not like that. So I think there's something else in this area. Again, the pelvis, Jean-Paul.
Can I put something in there? I was thinking about the question of Mr. Ijin Ginting. What makes it very difficult is that, like you say, Karolina, these aspects of our body are mutually influencing each other. So, for example, if you have a pelvic problem and by inflammation the SI joint will be in counternutation, it will place the facet joints in another position. You will see many patients with SI joint problems who have high tension in their erector spinae, which puts a lot of compression on the lumbar spine. So you very often see patients with combinations of problems because the function in this complete area is disturbed. Now, the big thing is that if you're going to do something like a denervation or a surgical operation, you must be absolutely sure that you are on the right spot. For us conservatively, it's much easier because if we are wrong, the consequences are not so big. So our test system we use is that we use the active straight leg raise test to understand if the mechanical stability of the SI joint is compromised. So that's the active straight leg raise test. We want to know if control in the pelvic area is somewhat disturbed by using this store extending test. And then we want to know whether there's counternutation. Therefore, we use the long dorsal ligament test, which is compression of the posterior iliac spines to see if the test is, that's the finger 14 test, to see if it's positive. So that's the 3 tests we use to find out whether somewhere the SI joint may be involved. But for us, it's much easier because we don't have to be too specific in finding what is wrong, because we're treating the whole system in our conservative approach. So for us, it's easier.
Thank you, Jean-Paul, for your wonderful comments. In my clinical case, I often experience a combination of sacroiliac joint and lumbar spine disease. Approximately 32% of mine. So we should focus on sacroiliac joint as well as lumbar spine area and more whole body conditions.
Yeah.
As you say, I have to learn from you more about the method to observe the whole body conditions.
Okay.
And Karolina, to your question, what I experienced after SI joint fusions, that the facet joint L5 is 1 on the fused side gets in trouble, and that there you have a spondyloarthritis more than on the other side. So it must be a single load of the L5 is 1 facet, and this pain is, many of us experience, is almost the same pain for the patient as an SI joint pain if you ask them where it is. So this is my experience after SI joint fusions, that they have facet joint pain on this fused side. So, but I have a question to you. You said that you have a lot of experience with radio frequency. Most of the lateral branches are captured with radio frequency in the studies. But my question is now, why do they not last longer than 6 to 12 months if you capture almost 100% of the nerves? So is this a re-innervation, or what is it after denervation?
I really have no idea, actually. Well, from the radio frequency or ablation point of view, you capture with bipolar, at least with bipolar technique, you capture almost 100% of the nerves. So you always have to think about the distance between the needles and the non-insulated tip of the needle. But if you choose wisely, then you should really get nice results. But anyway, a few weeks ago, we had a patient when we performed such an ablation, and after 2 days, she had even a pain increase. And I can imagine that for the few days you can have increase of the pain, but it was really debilitating, and it's much worse than before the ablation. So I think when we do anything, when we move, when we have trauma, when we age, there is some regrow of the nerves definitely between the ligaments, and after the lesion we see that also after the lesion of the for example medial branches for the facet joint pain, then we have this recovery for a few months, but then again, you just need to repeat the lesion. And for sometimes after, if you do it already 2 times, then I cannot even be able to stimulate this nerve. So I cannot find the right position of my needle. So it's becoming more and more complicated. I don't know what happens after 12 months after the ablation. We don't have actually anatomical study or immunohistochemistry study about it, and it would be nice to have it, but I don't know how we can have it. I have no idea actually. So I would say the nerves regrow, and maybe in different positions or in different layers of the ligaments, but where you have also with ablation, you also create trauma, of course.
My personal findings are that with endoscopic denervation methods, you have a longer lasting pain-free interval for the patients. So by removing all the soft tissue around the facet, for example, or at the medial border of the SI joint, then the results are better than with the needle methods. So this is my personal experience, because I do it just endoscopically and I do not use the needle techniques. So, but this is just, I don't know why this is, you know, because we don't do anything different to the needle technique. Yeah. Maybe a little bit more extensive, of course, because you can visualize it, but I don't know why.
Well, what I really do, I really measure the distance between two needles. So I always use the smaller distance than actually should be used between the 10 millimeter active tip. What my patients complain about usually after the lesion is the numbness of the buttock, and it lasts for a very long time, for a few months, and some of the patients do not recover from it. So and this is again now not funny, but remarkable actually. They still have this numbness in the sacroiliac joint area, but after a few months, after 12 months, the pain is SI joint comes back.
So they still have the numbness and the pain.
But then they have pain. So it's kind of the anesthesia dolorosa after the trigeminal nerve denervation. Yeah.
So I have another question to Jan Paul. What is the strategy in your clinic to achieve understanding and acceptance by those severe SI joint patients? Because this is fundamental, as you told us.
Yes, it is. Well, it's a rather difficult question, because it also has to do with the way you look at how you perform therapy and how you want to understand how the psychological mechanisms in people work. So if I tell you something which is different from what you heard for a long time, you want to believe because you want to get better, but you don't want to, you can't believe because it's something which is so different that you just cannot accept that that's what you're telling them. So you have people with pain, they've been to all kinds of specialists, they've heard they have the wasting and degeneration of some joints and things like that. They've heard they have to live with it. And then they come to us and we say, well, we can do something about it. They won't believe that. So what we do, and that's a therapeutical thing which is very important. You give a patient a little bit of information, and then you let them do an exercise which will confirm this little bit of information. In other words, we tell them, no, you have this pain because you are overloading the joint. The joint cannot be loaded so much. You really quickly overload it. So if you take more resting moments, you will see that in 1 or 2 weeks, the pain will get less. The first days you will have a bit more pain because you feel how fatigued you are. This will be a bit more, but then after 2 or 3 days, it will get better. Then we put them in the right position to be really relaxed. And then after 2 or 3 days, the patient comes back and he says, well, you were right. At first, it was a bit painful and it was very fatigued, but now it feels better. What can I do next? And then the patient starts asking you for more information. And then you start the information, activity, emotional feedback process. And that helps the patient in getting to change the behavior. And that's what you do. Is that an answer to your question, Volker?
Thank you.
Okay.
So, any more questions?
Any more questions? Okay. I have some questions, but time is up. And I'd like
I just put on the screen to be polite to the sponsors. So if you have more questions,
Michael.
Yes.
Can I ask you something? I don't know if there are any other questions to me, but you can also send them afterwards to me, and I will answer the questions by mail if possible.
Yes, I will do.
Okay, thank you.
So, Michael, I'd like to get a comment from Dr. Bengt Strassen, who is now attending this meeting. I heard that Dr. Strassen collaborate with Dr. Jan Paul. So, do you have any comments for this webinar, if possible? He's absent.
Oh, there he is.
Here I am.
Here I am. Oh, thank you. Thank you for attending this meeting today.
I think, from my point of view, I think it was a very good seminar, and we have focused on rehabilitation on patients with severe pain in the pelvic area. That is, well, of course, there's a lot of things to talk about because I don't usually see those patients who failed with all physiotherapy, who failed with spine and joint treatment. That is my patients. And I think it's so important to realize that we see patients in different, how to say, part of the pain situation. So it's, but we raised a lot of good questions here today, and I have been very positive. I think that this was the best meeting I ever had participated with SIMEG. Really good meeting.
Yeah,
really good.
Thank you very much for your comment. I'm very happy to meet you in this webinar.
Yeah, well, I'm also happy with that, and I would be even more happy to see you in 1 month or what, something like that in Sweden. Yes.
Maybe that's a good opportunity to announce our 10th anniversary meeting on September 22. It will be in Germany, and we will announce it on the website. September 22 and 23. 10th anniversary meeting of SIMEG.
So, any more questions? No question from you, Bengt. I'm very astonished.
Well, you know, we are focused on a very, very difficult subject, and it's hard to push in one way or another. but I'm happy that we cover the diagnostic part so much. From my point of view, we always look at the ability to load. Because usually it is, and this was shown with many of us today, but my patients, they usually can't load. They come in with a bad limp. The interesting thing that we do the sacroiliac block, and if the patient had a good effect of the sacroiliac block, that means that they have the ability to load again. And if they can walk again, then we think this is a very positive effect. We discussed the effect of the block, both intra-articular and peri-articular. The case is if I would suggest surgery, I need to have a patient that has a good ability to load after the block. Then I usually refuse those who can't load. I mean, if I do a sacroiliac block and they don't have a good effect, that I refuse them for surgery. Maybe I should do peri-articular blocks on these patients as well. But then I don't know, because usually I think the reason of doing surgery is to remove pain and make it possible to load and walk again, because the point is that the patient needs to use the muscles, and those who can't walk, they can't use the muscles, and all our treatment is to make it possible to load, to have the muscle function back. So this, we raise a lot of questions, but it's important to see that we all want to come to the same way to restore the life for the patient. So from my perspective, it's ability to load. That is the most important thing.
Thank you very much for your comment. The last time I performed the sacroiliac joint fixation for my patient, but he couldn't walk well now. So my colleague, physical therapist, mentioned to me that he couldn't load his legs even after the sacroiliac joint injections, but the pain was dramatically decreased. So I should confirm the degree of load after sacroiliac joint injection, as you said. It's a very important point to find out before surgery.
Well, I think it's very, if I respond to that, it's very important because patients, they want to be healthy. So if you do whatever you do, and they say, oh no, I have no pain and so on, please do a surgery on me, then they can easily cheat the doctor, and because everybody want to be perfect. That is the point of life. So I think that is one of the tricks. We shall not be cheated. Because if we are cheated, we don't help the patients at all. Then we re-cheat them more or less. So that is it is a really tricky situation. I work in a very tricky situation as well, because it's not so easy for me to see the patient again next week. I live in the long country. And in the very south, and the patient come from the whole country to 2,000 kilometers sometimes, and I can't take them back in next week and make a second block after 2 weeks because they have to fly over the whole country. So that is also a tricky situation. So nevertheless, to summarize my point of analysis, I do a lot of testing. I do good block, and the check is I can a load gain after the block. But that's the case, and I use my physiotherapist always. He's the best guy because he do the post-op or post-block testing, and not it's much better than if he do it than I do it. So it's well, there were a lot of comments, but it was a very good meeting today, I think.
Thank you very much.
Here it's raining outside, so it was very good to sit at the computer.
Thank you. So if there are not, I can't see any question anymore. Michael, do you have anything?
No.
So I think we can close the meeting. And looking forward to the next one. We announce it on our website. And looking also forward to the anniversary meeting, as you already announced. And hopefully the next meeting will be as enlightening and as good as this one. So thank you for participating and joining us, and thank you for supporting by Autobox, SIMEG, and PowerFind, and thank you to the speakers. It was a very nice and a very good meeting. Thank you.
Thank you, Volker.
Bye-bye.
Hope to see you another time. Bye-bye.